Welcome back to another deep dive. Today, I want to start by asking you to picture a scene. It's London, maybe 1850. It's foggy cobblestone streets. You can hear the horse-drawn carriages clattering by. And inside some dimly lit room, there's, a poet or an artist looking tragically pale, coughing gently into a handkerchief.
Ah, yes. The romantic disease, consumption.
Exactly. We're talking about the White Plague or consumption. It's the disease that killed Keats, Chopin, Orwell, Chekhov. I mean, in literature, it has this tragic glamour to it.
It does. It makes the sufferer seem delicate, almost ethereal.
Right. But when I started digging into the stack of research for today, the reality of it just hit me like a freight train. This is not some plot point in Les Miserables.
Far from it. That Victorian disease is, right now, the world's leading infectious killer. I mean, depending on the year, it surpasses HIV and malaria.
Wow.
Yeah, that whole romantic image. It falls apart really, really quickly when you actually look at the biology.
It really does. And the scale of it is what I think people, and I'll include myself here, struggle to wrap their heads around. We sort of assume we beat this thing when we invented antibiotics.
Of course. It feels like a solved problem.
But then you look at the numbers. Globally, right now, there are 2 billion people infected.
That's the number. That's the one that always stops people in their tracks. 2 billion.
It's almost incomprehensible.
It is. I mean, think about it. That is roughly 1 out of every 4 people walking the planet today. Now, to be clear, that doesn't mean 2 billion people are in hospital beds coughing.
Right.
But they're carrying the passenger.
And that's the distinction, I think, that we need to make right away, because it's the core of why this silent giant is so successful. You can have tuberculosis or TB and have absolutely no idea.
Zero idea.
You aren't sick, you aren't contagious, you're just a vessel.
Precisely. And that's our mission today, really. We need to unpack how this organism, Mycobacterium tuberculosis, pulls off that magic trick.
How does it
invade the body?
Yeah.
How does it build a literal fortress inside your lungs to hide, sometimes for decades?
And then what does it take to get it out? Because the treatment regimen, wow, it's arguably one of the most intense marathons in all of modern medicine.
A marathon is a good word for it. It's not a sprint.
Not at all. We're talking about, and we'll get into this, orange tears, nerve damage, and government-mandated chaperones. It's wild.
It is.
But let's start at the beginning with the antagonist itself, Mycobacterium tuberculosis. It's a bacteria, but it doesn't behave like, say, your average strep throat.
No, it's a particularly stubborn organism and has this waxy coating on its cell wall, a lipid layer, that makes it incredibly hardy.
Hardy how?
Well, it's resistant to drying out, for one. It can survive for a while outside the body. It's resistant to a lot of disinfectants. But the key thing, the most important thing to understand, is how it travels. It is strictly airborne.
Okay, so this isn't something I can pick up from a doorknob or a handshake or sharing a drink.
Absolutely not. You need to breathe it in. It travels on what we call droplet nuclei, these tiny, tiny aerosolized particles that get expelled when someone with active disease coughs or sneezes or talks or even sings.
And because the particles are so small, that's what lets them get so deep into the lungs, right?
Exactly. They're so small, they just bypass all the normal defenses in your nose and your upper throat, and they can settle deep, deep in the alveoli, the very bottom of the lungs.
The research also highlights that this usually requires close contact, so you're not likely to get this just walking past someone on a windy street corner.
Correct. It's really a disease of shared air. That crowded apartments, prisons, homeless shelters, barracks, even long flights.
Yeah.
You need to be sharing that same volume of air for a significant amount of time.
Okay, so let's walk through this scenario. You're in a room, you share that air, and you inhale the bacteria. It lands in the lungs, usually the lower lobes, you said.
Typically, yeah, just because of the physics of airflow.
What happens next? Does the body just let it set up shop?
Oh, not without a fight. This is where the story gets really fascinating biologically. Your immune system, specifically the first responders called macrophages, which are the eater cells of the immune system, they rush to the scene.
And their job is to just gobble up invaders.
Their job is to gobble up invaders, digest them, and present the pieces to the rest of the immune system. In most infections, like a common pneumonia, that's the end of it. The macrophage eats the bug, digests it, game over.
But I'm guessing TB is different.
Tuberculosis has evolved specifically to survive inside the macrophage.
Wait, inside it?
Yes. It essentially gets eaten, and then it has mechanisms to prevent the macrophage from digesting it. It just hangs out inside the very cell that was sent to kill it, and it starts replicating.
That is just, it's insidious. It's a Trojan horse.
It's the perfect Trojan horse. So the immune system, after a while, it realizes, okay, plan A isn't working. We can't kill this thing. So it has to change tactics.
So what's plan B?
Containment. Instead of trying to eliminate it, the body decides to imprison it. It recruits more and more immune cells, T cells, lymphocytes, to surround the infected area. It starts building a wall, layer by layer. This structure is called a granuloma.
I want to linger on this granuloma concept because the visuals here are incredible. It's basically a biological jail cell.
That's the perfect analogy.
Yeah.
It is a biological jail cell. The center of the granuloma is the stuff called caseous necrosis. It's this cheese-like necrotic tissue made of dead cells and bacteria.
Cheese-like, that's a lovely image.
It's a classic pathology term. But around that necrotic center, you have this highly organized ring of immune cells. And eventually, the body lays down a layer of fibrous tissue and then calcium. It literally calcifies the whole thing.
It turns it to stone.
It turns the infection site into a tiny stone, a tomb.
And this leaves a permanent mark, doesn't it? This is the Gonin complex that you see mentioned in the pathology notes.
Yes. So if you look at a chest x-ray of someone who fought this initial battle and won, you can sometimes see the Gonin complex. It's a very specific combination of two things.
Okay.
You have the calcified lesion in the lung tissue itself.
Yeah.
We call that the Gonin focus. That's where the battle happened. But you also see calcification in the nearby lymph nodes, where the immune system drained the fluid from the battlefield.
So the scar is in two places.
Exactly. The battlefield scar and the scar in the command center, the lymph node. That combination of a radiodense, calcified spot in the lung plus a calcified lymph node. That is the Gonin complex. It's the tomb of the infection.
The tomb. That sounds pretty final.
And for about 90% of people with a healthy immune system, it is. We call this latent TB infection. The bacteria are trapped inside that calcified prison. They aren't dead, but they're metabolically almost at zero. They're just hibernating.
So the person isn't sick.
Not sick at all.
They aren't contagious.
Not contagious at all. They go about their lives totally normal. They just have this positive skin test, which shows their body has seen the bug before.
But here's the terrifying part and the key to this whole disease. The bacteria aren't dead. They are just waiting.
They're waiting for a jailbreak. And this is the fundamental difference between latent infection and active disease. 2 billion people have the infection the prison is holding. But for about 10% of those people, at some point in their lives, the walls crumble.
What causes the walls to crumble? What triggers that?
Anything that weakens the guards. I mean, the immune system requires a lot of energy and constant vigilance to maintain those granulomas. So if you get old, if you develop diabetes, if you get put on chemotherapy or high-dose steroids.
Things that suppress the immune system.
Precisely. Or even things like severe malnutrition. The immune system gets distracted or weakened. The structural integrity of that granuloma fails. The bacteria inside wake up, they start multiplying, and they break out.
And once they break out, they're not contained anymore. They can go anywhere.
Right. They can spread locally in the lungs, usually to the upper lobes where there's more oxygen, and cause that classic cavitary pneumonia. Or, and this is where it gets really dangerous, they can erode into a blood vessel and enter the bloodstream.
That's called hematogenous spread.
Yes. And once it's in the blood, it can go to the brain, the kidneys, the spine, anywhere. And there's a particularly devastating form of this called miliary TB.
Miliary, I was looking this up. It comes from millet seeds, right?
It does. It's an old term. Imagine taking a handful of tiny millet seeds and scattering them across a black tabletop. That's what a chest x-ray looks like in miliary TB. Thousands of tiny pinprick-sized granulomas scattered throughout both lungs.
Wow.
And it's not just the lungs. They're in the liver, the spleen, the brain. It happens when a massive amount of bacteria hits the blood all at once. It's an absolutely overwhelming infection.
So we have this silent sleeper agent in 90% of cases. And this reactivation risk is actually how most people in the U.S. get sick with TB, isn't it? It's not usually a new infection?
That's a critical point. In a low-prevalence country like the United States, most of the active TB cases we see are reactivations of old latent infections. Someone got infected decades ago, maybe in another country, and something in their life old age, a new medication, has allowed it to come back.
Okay, so let's talk about the biggest reason for that jailbreak. The data is just. It's incredibly clear on this. There is one risk factor that completely changes the game.
HIV. You cannot talk about the modern epidemiology of tuberculosis without talking about HIV. They are, unfortunately, the perfect partners in crime, a deadly synergy.
The statistic I saw was just staggering. An HIV-positive person with latent TB is it really 100 times more likely to develop active disease?
100-fold, yes. It's not 10%, it's not 20%. It's 100 times more likely than someone who is HIV negative.
Why? What is the mechanism there?
Well, think about what we just discussed. The granuloma, that prison wall, is built and maintained primarily by a specific type of immune cell, the CD4 T cell.
And CD4 T cells are the exact cells that HIV targets and destroys.
Exactly. So if you have HIV, you are essentially firing the prison guards. The bacteria don't even have to fight to get out. The doors are just left wide open. The containment fails completely.
And this changes how the disease actually looks, doesn't it? Because normally when we get sick, the symptoms we feel, the fever, the swelling, that's actually our body fighting back.
That's our inflammatory response.
So if you don't have an immune system to fight back, do you still look sick in the same way?
That's the clinical trap. In a patient with advanced HIV, their immune system is so depleted that they might not have the classic cavitary lesions, those big holes in the lungs, because they can't mount the intense inflammation required to create them.
So their X-ray might look less dramatic.
It might look like a regular pneumonia, or it might look almost normal. And even more confusingly, they might not even have a positive skin test.
How is that possible if they have active TB?
It's a phenomenon called anergy. The body is so beaten down, the T-cell army is so depleted that it can't even register a protest. You inject the protein and nothing happens. The body is too weak to respond.
Which has to make diagnosing it an absolute nightmare.
A nightmare. And you also see a much higher incidence of extrapulmonary TB outside the lungs because the containment is so poor, the bacteria just go everywhere right from the start.
Okay, let's set the HIV case aside for a moment and assume we are dealing with a classic case. The Victorian novel scenario. The immune system is fighting, but it's losing.
Yeah.
What does active TB actually feel like to the patient?
It's a slow burn. That's why it was called consumption. The disease literally consumes the body.
From the inside out?
Yes. The bacteria are metabolically active, they're replicating, and your body is pouring all of its energy and resources into this futile chronic war. So the first thing is weight loss. Massive, unintentional weight loss.
And fatigue.
Profound fatigue. You are just exhausted constantly. Then you have the fevers.
Are they high fevers? Usually low grade, but then you get the night sweats.
Yeah.
And we aren't talking about just being a little clammy.
We're talking drenching night sweats. The kind where you wake up and your pajamas and your sheets are soaked through. You have to get up and change them. That is a hallmark sign. And it's driven by a specific immune signal called TNF-alpha.
And then, of course, the cough.
A productive cough. It starts dry, but then it becomes wet, productive of sputum. And eventually, as the bacteria continue to destroy the lung tissue and erode into small blood vessels, you get hemoptysis.
Coughing up blood.
It can be just streaks of blood in the sputum, or it can be what we call frank hemoptysis, coughing up significant amounts of pure blood.
That has to be terrifying for the patient.
It's terrifying. You are literally seeing pieces of your lung destruction coming up.
So if I'm a doctor and a patient comes in with this story, and I put a stethoscope on their chest, what am I hearing? Is it obvious?
Rarely. That's the frustrating part. The physical exam is often non-specific. Over the affected areas, you might hear rales, which are like crackles, or you might hear dullness to percussion, where you tap on the chest, which suggests fluid has replaced air.
But nothing that screams tuberculosis.
Nothing that screams TB. You can't diagnose it with a stethoscope. You have to play detective, and that means you need to start the diagnostic gauntlet.
Okay, let's get into that. I want to start with the most common one, the test that most of us in healthcare have had dozens of times. The skin test, the PPD.
The Purified Protein Derivative Test, or the MAN2 test. It's a crude, old test, but it's still surprisingly effective.
So walk us through it. They take a tiny needle.
And they inject a tiny bubble of this protein extract, which comes from the TB bacteria, right under the very top layer of skin on your forearm. It creates a little bleb or wheal.
And then they tell you to go away and come back in 2 or 3 days. Why, wait, what's happening under the skin?
Because this isn't an immediate allergic reaction like a bee sting. It's what we call a delayed type hypersensitivity. We are waiting for your immune system's memory cells, your T cells, that are patrolling your body to pass by the injection site. If they recognize that protein from a previous encounter with TB, they sound the alarm. They release chemical signals that recruit a whole team of other immune cells to the site to attack it. That recruitment process, that buildup, takes 48 to 72 hours.
Okay, so you go back to the nurse, and this is where I think people get confused. I always thought if it turned red, that was a bad sign, but that's not actually what they're looking for, is it?
No. Redness or erythema means nothing. You could have a giant red patch and still be negative. What we are measuring is induration.
Hardness.
Hardness. The nurse has to do it by feel. They run their fingers over the site. They're looking for a raised, firm, palpable bump. That bump is the physical accumulation of all those immune cells that showed up for the fight. They measure the diameter of the hard part in millimeters.
So measuring the bump seems simple enough, but then I saw the criteria for what actually counts as positive, and well, it's complicated. It's not one size fits all. It depends on who you are.
Exactly. It's all about risk stratification. We don't have a single number that means positive. We have 3 different cutoffs: 5 millimeters, 10 millimeters, and 15 millimeters.
Okay, let's break that down. Who falls into the 5 millimeter group? That's a tiny bump. I mean, that's basically a mosquito bite.
Right. A 5 millimeter induration is considered positive only in the highest risk people. So this includes people with HIV, anyone on immunosuppressive drugs like long-term steroids, or someone who is a recent close contact of a person with active TB.
So why is the bar so low for them?
Because we know their immune system is compromised. They might not be able to mount a big response. So for them, even a tiny reaction, a tiny bump, is a screaming alarm bell. It's a significant signal.
Okay, that makes sense. Then we have the 10 millimeter group. This is the middle ground.
This captures the increased risk population. This is a broader category. It includes recent immigrants from high-prevalence countries, so someone who arrived in the last 5 years. It includes injection drug users.
Why that?
There's a strong association with risk behaviors and also some immunosuppression. This category also includes residents and employees of high-risk congregate settings. Think jails, nursing homes, homeless shelters.
And lab workers.
And lab workers, right. People who might be exposed at work.
Yeah.
For them, we need a bit more evidence than the first group, so the bar is set at 10 millimeter.
And then finally, 15 millimeters. That's a pretty large welt.
That's for everyone else.
Yeah.
People with absolutely no known risk factors. If you are a healthy 25-year-old living in the suburbs who never travels internationally, and you get a 10 millimeter bump, we might call that a false positive or just non-specific reaction. But if you get a 15 millimeter bump, that is undeniable. That means you have the infection. We have to take it seriously.
Now, there's this concept in the diagnosis section of the research that I found completely bizarre, the booster effect. It sounds like something from a video game, but it's actually about our immune system being, forgetful.
Forgetful is a good way to put it. Or maybe just asleep at the wheel. So imagine a patient, let's say an elderly person, who had a primary TB infection 50 years ago. Their immune system walled it off beautifully, created that granuloma, and then it went dormant. The memory T cells are still there, but they've been in a sort of coma for decades.
Okay, so you give them a routine skin test.
And it comes back negative.
Yeah.
0 millimeters of induration. The immune system is just too groggy, too slow to mount a response in that 48-hour window. So the doctor thinks, okay, you're clear.
Yeah, you're not.
You're not. That first test, even though it was negative, acted like a slap in the face. It went an alarm clock. It woke up the immune system. It boosted the memory of that old infection.
So if you test them again, say a week or 2 later?
Suddenly they test positive.
Right.
A huge 20 millimeter bump. Now, if you didn't know about the booster effect, you'd look at that and think, oh my God, this person just caught TB this week. Between test 1 and test 2.
Which would cause a panic.
A huge panic. But it's not a new infection. It's the old infection finally showing up because the first test woke up the guards. We do 2-step testing in places like nursing homes, specifically to catch this.
That is wild. It just shows how fallible these tests can be if you don't understand the biology behind them. But okay, let's say the test is positive. You've got the bump, you've got the cough, the night sweats. You get a chest x-ray and it shows cavities in the upper lobes. You have active TB. Now comes the hard part, the treatment.
The treatment for TB is a masterclass in persistence. And the strategy is built on 2 core concepts: aggression and patience.
Let's start with aggression. Why can't we just give them a strong antibiotic like we do for other infections and call it a day? Why is the absolute golden rule that you never, ever use just one drug for active disease?
Because tuberculosis is a master of mutation. In any given population of billions of bacteria inside a patient's lungs, there are, just by random chance, going to be a few mutants that are naturally resistant to drug A. If you only give drug A, you'll kill 99.9% of the susceptible bugs. The patient will feel better for a little while. But you've left that handful of resistant mutants alive.
And they're the only ones left.
They're the only ones left.
Yeah.
So they multiply, and within a few weeks, the entire infection is now made up of bacteria that are 100% resistant to drug A. You haven't cured the patient, you've just created a drug-resistant monster.
So you have to hit them with everything at once to cover all your bases.
Exactly. You use a minimum of 2, but usually 3 or 4 drugs, all with different mechanisms of action. It's like locking all the doors and all the windows simultaneously. The chance that one bacteria is randomly resistant to all 4 drugs at the same time is astronomically low.
So let's talk about the cocktail. The acronym I kept seeing is RIPE. RIPE.
That's the one. It stands for the 4 first-line drugs: rifampin, isoniazid, pyrazinamide, and ethambutol. This is the A team, the heavy hitters.
And a patient with active TB takes all 4 of them.
For the first 2 months, yes. Every single day, this is the intensive phase. The goal here is to drastically reduce the number of bacteria in the body. To kill off all the rapidly dividing ones, you are throwing the kitchen sink at them.
And after 2 months?
After 2 months, if the sputum cultures show that the bacteria are retreating and are susceptible to the main drugs, you can drop down to just isoniazid and rifampin for another 4 months. That's the continuation phase.
So 6 months total, minimum.
Minimum. That is the absolute shortest course for standard drug-susceptible pulmonary TB. And that's if everything goes perfectly.
Now, I'm trying to put myself in the shoes of a patient. I feel terrible. I'm coughing up blood. I've lost 20 pounds. I start taking these 4 pills every day. After maybe 3 or 4 weeks, the drugs start working. I feel much better. The fever breaks. I gain a little weight. My instinct is to say, great, I'm cured, and stop taking the pills. Especially because, as we're about to discuss, the side effects are nasty.
That instinct is the single biggest enemy of TB control globally. If you stop at 2 months because you feel better, you haven't killed the semi-dormant bacteria, the persisters. You've only killed the easy ones. The infection will come back, and this time it will almost certainly be resistant.
So how do we stop people from quitting? The solution mentioned in the research is, honestly, it's pretty controversial if you think about it in terms of civil liberties, DOT, directly observed therapy.
It is the standard of care in the United States and recommended by the WHO. It means that you do not take your medication alone at home. A public health worker, a nurse, or a trained outreach worker must watch you swallow every single dose.
They physically watch you put the pills in your mouth and swallow.
Yes. They might meet you at the clinic, or they might come to your house or your workplace. They watch the pills go in your mouth. They watch you swallow. They might ask you to speak to them afterwards to make sure you didn't cheek them.
That feels incredibly intrusive. I mean, can you imagine explaining to your boss, hey, a government nurse needs to come to my cubicle to watch me eat a pill at 10 a.m. every morning?
It is intrusive. And there's always a debate about patient autonomy. But you have to weigh that against the immense public health risk. An untreated or poorly treated TB patient is a biological weapon, to put it bluntly.
Right.
They continue to spread the disease to their family, their neighbors, the person on the bus. And if they breed a resistant strain by being non-inherent, they're spreading a version of the disease that we might not be able to cure at all. So society has decided your right to privacy ends where the public's fundamental safety begins.
It makes a grim kind of sense, but it's heavy. And I imagine it's even harder to enforce when the patients realize what these drugs are actually doing to their bodies. Let's talk about the personality of the RIPE drugs, because just saying side effects sounds too mild. These drugs are wild.
They are toxic.
Yeah.
They're necessary, but they're absolutely toxic.
Yeah.
Let's start with rifampin, the R in RIPE.
Okay, this is the one that causes the orange tears. This sounds like an urban legend, but it's real.
100% real. Rifampin is a molecule with a deep reddish-orange pigment. It is excreted in all bodily fluids, and it turns your urine, your sweat, your saliva, and your tears a bright reddish-orange color.
So you're literally sweating orange.
Yes, and it stains fabrics. If you wear a white t-shirt to the gym, the armpits will turn orange, and it will never wash out. But the big, big warning we give every patient is about contact lenses.
What happens?
If you cry, or even if your eyes just water while you're wearing soft contact lenses, the lenses will be permanently dyed orange. You won't be able to see through them properly. You have to switch to glasses for the entire 6 months.
Imagine the psychological impact of that. You're trying to go about your day, maybe hide the fact that you're sick, but your body fluids are neon orange. It's like a scarlet letter.
It is. And beyond the color, rifampin is a nightmare for drug interactions. It's a potent inducer of liver enzymes. It revs up the liver like a V8 engine.
What does that mean for other medications?
It means the liver starts metabolizing other drugs super, super fast. So if you are on birth control pills, blood thinners like warfarin, heart medications, methadone, rifampin just chews them up and spits them out. Your other meds stop working.
So you could get pregnant or have a stroke because your TB meds ate your other meds?
Precisely. It requires a pharmacist to basically overhaul your entire medication list for the duration of therapy. It's a huge issue.
Okay, that's rifampin. What about isoniazid, the eye?
Isoniazid's main personality quirk is that it targets the nerves. It can cause a dose-dependent peripheral neuropathy.
So nerve damage, what does that feel like?
Tingling, numbness, a pins and needle sensation, or even burning pain, usually in the hands and feet. A stocking in glove distribution. It does this by interfering with the metabolism of vitamin B6.
The drug literally steals your vitamins.
It interferes with how the body uses pyridoxine, which is vitamin B6. So the fix is actually pretty simple. Whenever we prescribe isoniazid, we almost always co-prescribe a B6 supplement to take with it.
And that prevents the nerve damage.
It prevents it in most people. We're especially careful to give it to patients who are already at risk for neuropathy, like pregnant women, alcoholics, or diabetics. If you don't, the nerve damage can become permanent.
Okay, then we have ethambutol, the E. This one scared me the most when I was reading about it.
The eye toxicity, yes. This is a big one. It can cause something called retrobulbar neuritis.
It sounds bad.
It is. It's an inflammation of the optic nerve behind the eyeball. It can cause blurry vision, which is bad enough, but its most specific and classic side effect is that it causes a specific type of color blindness. Patients lose the ability to distinguish red from green.
Red from green, so traffic lights, stop signs.
Exactly. Imagine driving and not being able to tell if the light is stop or go.
Yeah.
Every single patient starting ethambutol needs a baseline eye exam, and they need to be tested monthly. We literally hold up color charts and ask them to read the numbers. The moment they start hesitating on the red-green plates, we have to stop the drug immediately.
And finally, pyrazinamide, the P in RPE.
This one messes with how the kidneys handle uric acid. It can cause hyperuricemia, which, in some people, can precipitate an attack of gout.
Gout is incredibly painful, right? People describe it as feeling like shards of glass in your joints.
Yes, classically in the big toe. But it can manifest as general joint pain polyarthralgia.
So let's just recap the potential patient experience for a moment.
Okay.
You are sweating orange, your hands and feet are numb and burning, you can't tell red from green, and your joints feel like they are full of broken glass.
And a nurse is watching you every day to make sure you keep taking the pills that do this to you.
For 6 straight months.
It really puts the compliance or adherence problem into perspective. I mean, I complain about taking a 5-day course of an antibiotic that gives me a mild stomachache. This is a different universe of suffering.
Now, we haven't even touched on the one side effect that's common to almost all of them.
The liver. Isoniazid, rifampin, and pyrazinamide are all potentially hepatotoxic. They can damage liver cells, so we have to draw blood constantly, usually every month, to check their transaminases.
Those are the liver enzymes, LFTs.
Right. When liver cells die, they burst and release these enzymes into the blood. If those enzyme levels go too high specifically, the rule is more than 3 to 5 times the upper limit of normal Vitrindi. We have to stop everything.
You just stop all the drugs.
You stop them all before the patient goes into acute liver failure. You wait for the liver to recover, and then you have to very carefully reintroduce the drugs one by one to figure out which one was the culprit. It's a constant balancing act between killing the TB and killing the liver.
Now, what happens when this A-team fails? We mentioned the risk of resistance earlier. Let's talk about MDR-TB, multi-drug resistant TB. This is the global health nightmare scenario.
MDR-TB is defined very specifically as resistance to the 2 most powerful, most important drugs, isoniazid and rifampin. If you lose those 2, you have lost your heavy artillery. The whole REPE regimen is compromised.
And how does this happen? Is it just people stopping their meds midway through?
That's one major way we call that acquired resistance.
Yeah.
But you can also be infected directly with a resistant strain from the start. If I have MDR-TB and I cough on you, the TB you get is MDR-TB from day 1. This is common in certain parts of the world, like the former Soviet states, Southeast Asia.
So how do you treat that if MDR and I are off the table?
You have to go to the second-line agents. This is the B team and the C team. These are drugs that are generally less effective at killing the bacteria and, unfortunately, much more toxic to the patient. We're talking about injectable drugs like amikacin, which can cause deafness and kidney failure, fluoroquinolones, and other older, nastier drugs.
And the treatment duration isn't 6 months anymore, is it?
Oh, no. For MDR-TB, you're looking at 18 to 24 months of therapy, sometimes longer. 2 years of daily, highly toxic drugs.
2 years. That's devastating.
And the cure rates drop significantly from over 95% for normal TB down to maybe 50 or 60% for MDR-TB. It's a dire, dire situation.
The research flagged a few special scenarios I want to touch on quickly. Pregnancy. Treating a pregnant woman is always terrifying because you have 2 patients to worry about.
It is, but the absolute rule is you must treat active TB in pregnancy. Untreated TB is far more dangerous to the fetus than the drugs are. The disease itself can lead to low birth weight, premature birth, and can be fatal to the newborn if transmitted.
But you can't use just any of the drugs, so some are off limits.
Absolutely. The main one that is absolutely forbidden is streptomycin, an older injectable drug. It crosses the placenta and is ototoxic. It damages the developing auditory nerve in the fetus. It causes congenital deafness in the baby.
And another one, ethionamide.
Also considered dangerous. It's been associated with severe congenital deformities, including some Down syndrome-like defects. So we stick to the safer options. Isoniazid, rifampin, ethambutol are generally considered safe, but we watch that mom like a hawk, and we always give her vitamin B6 with the isoniazid.
One last group, renal failure. People on dialysis. My first thought was, if your kidneys aren't working, you can't clear the drug. So you just give less of it, right? Like you cut the pill in half.
That's the intuitive thought, but for TB, it's the wrong approach. To kill M. tuberculosis effectively, you need the drug concentration in the blood to hit a high peak. If you give half a pill, you get a low flat level, you never hit that peak, and the bacteria can survive it.
So what's the solution if the kidneys can't clear the drug and you can't lower the dose?
You change the interval, you give the full massive dose to hit that bactericidal peak, but instead of giving it every day, you give it 3 times a week, usually timed to be administered right after their dialysis session, which then helps clear some of it out.
So you let dialysis do some of the work.
Exactly. It's about spacing, not about lowering the dose. You maintain the punch, you just throw it less often.
It's amazing how precise all of this has to be. It's not just take 2 of these and call me in the morning. It's geometry and timing and chemistry and social work, really.
It's precision warfare against a very, very old enemy.
So we've tracked this disease from the 19th century poets to the modern HIV ward. We've looked at the calcified tumors in the lungs, the orange tears, the nerve damage, and the sheer logistical and personal nightmare of curing it.
It really is a lot to take in.
It makes you look at that 2 billion number differently. It's not just a statistic. It's 2 billion potential ticking time bombs.
It is. And that leads me to one final thought, if I can. We talked earlier about the booster effect with the skin test.
Yeah.
How the body can sort of forget about the enemy until it gets a specific reminder. I think that applies to us as a society, too.
How do you mean?
Well, in the West, in developed countries, we've largely forgotten about TB. We think of it as history, as a disease of the past. But the bacteria hasn't gone anywhere. It's lying latent in 1/3 of the world's population. It's just waiting for the global immune system, our public health funding, our political stability, our attention to weaken.
And as we saw with the rise of HIV, or even with how COVID disrupted healthcare systems.
Exactly. When the guard goes down, TB wakes up. It's always there, waiting for an opening.
The silent giant doesn't sleep. It just waits.
It just waits.
Well, on that cheerful note, but seriously, thank you. This was a massive topic, and I feel like I finally understand the mechanics of the enemy.
It's an enemy we have to respect. It's earned it.
Absolutely. Thank you for listening to this deep dive. Stay healthy, stay curious, and we'll catch you on the next one.